Hello, my name is John DeWitt, and I'm Professor of Medicine at Indiana University Health Medical Center in Indianapolis, Indiana. And I'd like to bring to you another edition of the GIE Author Interview Series. This paper that I'd like to discuss is our recent publication entitled Sonographic and Cyst Fluid Cytologic Changes Following EUS-guided Pancreatic Cyst Ablation. For the last 10 years at our hospital, we've been offering cyst ablation in patients who have EUS or clinical features that generally meet requirements for surgery. This could include abdominal pain or pancreatitis, perhaps some atypical cells on cytology, or the presence of mural nodules on imaging. In patients who have cysts between 1.5 and 5 centimeters, we have been offering ablation in patients who either are afraid to undergo surgery or perhaps are not candidates for it after surgical consultation. Between 2004 and 2009, we offered alcohol alone, and beginning in 2009, we combined alcohol injection with paclitaxel injection based on the work from Korean researchers showing that ablation rates appeared to be increased when paclitaxel was added. Our protocol has typically been patients coming for a baseline evaluation, at which time sonographic information such as cyst wall diameter, the presence of nodules, etc., were recorded. Patients that underwent final aspiration and cytology evaluation, and for 5 years from 2004 to 2009, alcohol injection was performed alone. In 2009, we added a paclitaxel injection, as I previously mentioned. The patient would come back 2 to 3 months later. The ultrasound features again were recorded, final aspiration was performed, and when there was a suboptimal response, repeat ablation was again performed. Patients then underwent cross-sectional imaging at least once within the next 12 months, and at least annually thereafter. The response to ablation we have recorded as based on the cross-sectional imaging size compared to the original volume. In patients who have a less than 5% original volume after ablation, we consider that a complete response. In patients who have a 5 to 25% response, we consider that a partial response, and in those who have greater than 25% of their original volume left over after ablation, we consider that a persistent cyst. For this study, what we have done is evaluated what are the sonographic changes after ablation and what are the cytologic changes after ablation, to see if we can provide further evidence that there are predictable changes and that may show that ablation produces objective changes. So for the study, we had 36 patients, 8 of whom received alcohol alone, and an additional 28 who got alcohol plus paclitaxel injection. Of these 36, 56% or 19 had a complete response. The remaining 17 had either a persistent cyst or a partial response. Sonographically, these patients typically have thickening of their cyst wall. They may have mural calcifications develop. They also may have loss of an epithelial or a mucin nodule present within the cyst wall. These changes, we believe, reflect ablation of the cyst wall epithelium. The thickening reflects a presence or an advent of inflammatory cells and scarring within the cyst wall. The loss of the epithelial or mucin nodule certainly reflects destruction. And cytologically, as you would expect, when you have cell wall destruction, you would have more inflammatory cells, perhaps more debris, and calcifications within your cyst fluid that you aspirate. And in fact, this is what we saw. Based on our previous work published in 2014, we saw that mutant DNA may be lost following ablation. And carrying this one step further, in 20 patients who underwent alcohol and paclitaxel injection, we noted that DNA quantity increases and quality decreases, again reflecting cell turnover. When we tried to correlate this with degree of response, unfortunately there was nothing that was predictive either sonographically or cytologically to predict who might or might not respond to ablation. So what did we conclude? We concluded that cyst ablation does produce sonographic and cytological changes, and this provides further evidence, in addition to changes on surgery and radiology, that these patients are undergoing cyst wall epithelial destruction, and that this technique does produce objective changes. Unfortunately, we could not predict which patient would respond completely with either the sonographic or cytological changes, but that this area provides some additional research that needs to be done. We believe this technique provides an alternative to patients who undergo or cannot undergo surgery or do not want to undergo observation, and we hope that this information provides more people to evaluate this exciting new technique. And I thank you for your attention.